Rising concerns over antimicrobial resistance and the cost of new drug regimens and the need to monitor emerging diseases have placed the development of affordable and accessible diagnostics centre stage of global infectious disease research and development. So we now live in a world in which overdiagnosis of disease in wealthy countries is coupled with the almost absence of diagnosis in many developing countries. Now, diagnostic tools have many different uses. They're crucial for the management of both individual and population health. They make important for making effective therapeutic decisions, for monitoring the effectiveness of interventions, for determining the susceptibility to drugs, for determining drug resistance, and monitoring emerging disease outbreaks, which was seen most recently in the case of Ebola. Now, the challenge of developing diagnostic tools that meet these needs in low-resource settings is clearest when we look to the actual places where these tools would be used. Places like this aid post in rural Papua New Guinea, which has no electricity, is several days' walk from the nearest road, and is staffed by a community health worker with grade 6 education and no laboratory training. As the WHO criteria for effective point-of-care diagnostics for resource-poor settings shows, the demand on devices that might work in such settings are very high. Moreover, trade-offs are often required between these different criteria, so these diagnostics need to be affordable, they need to be sensitive, specific, user-friendly, rapid and robust, equipment-free, often this means electricity-free, delivered, and I've also added in there, which isn't in the original criteria, connected. There's a growing recognition that diagnostics need to be connected in to health information systems. And often there is a kind of trade-off involved here between sensitivity and specificity and being equipment-free. Over the past decade, I've conducted health systems research in Medina Province, Papua New Guinea, and this has involved ethnographic fieldwork in multiple sites, including the provincial hospital, the government provincial health office, which is responsible for the administration of rural health services, and health centres in several rural districts, like the Asino Bundi district, which is depicted in the final image over there. Now, this research has involved various methods, including tracking patients' pathways to care, observation of clinical practices at health centres and in hospital wards, observation of laboratory practices at the provincial hospital, the observation of the coordination of supply and distribution systems at the provincial health office, and alongside interviews with clinicians, with technicians, pathologists, administrators, and patients. And this really broad research has enabled me to map the province's diagnostic infrastructure and to track the ways in which that infrastructure has changed over time. So to give a really simple version of this model, diagnostic equipment and treatment options at rural health centres, like this one here, are very limited. Until 2013, for example, all patients who presented to this health centre with fever would be treated presumptively for malaria, and most were also given broad-spectrum antibiotics. It was impossible to treat for other diseases that present with similar symptoms like dengue or meningitis. So instead, the health centre relied on patients returning in the case of treatment failure. And it was at that point that health workers might consider referring patients to the provincial hospital. The delay in referral, the distance to the hospital, and the expense of transportation, and this map shows actually that there's about a 5 or 6 hour walk from this health centre to the nearest highway, which is then about a 2-hour journey by bus to the hospital. So these patients would have to be carried, usually by several family members, in order to get to the highway. So this delay in referral and distance to the hospital meant that patients often arrive at the hospital from rural areas when they're already very sick. So often they're displaying very general symptoms, such as fever, nausea, abdominal pain, respiratory difficulties, or even a loss of consciousness. And doctors like to call these patients generally, what they call generally sick. But the diagnostic facilities at the hospital itself are also very limited. So Medina Hospital serves a province of 500,000 people. Officially, the hospital has a laboratory with facilities for haematology, histology, and biochemistry. But unreliable supply systems mean that the hospital is often short of reagents, the equipment is outdated and difficult to calibrate, and there's a perpetual shortage of staff. Frequent power outages also mean that reagents are often stored or tests are carried out at inappropriate temperatures. And in the ward, this leads to a general lack of trust in laboratory tests. So clinicians are much more likely to draw on their own experience and on clinical diagnosis to make management decisions than test results. So as in the health centres, generally sick patients often arrive and they're often admitted to the ward without any specific diagnosis. In fact, often patients only actually receive a diagnosis when they are discharged. And so they're usually treated also with antimalarials and antibiotics. Now, sometimes further tests are carried out, such as lumbar puncture for meningitis, ultrasound scan, or an X-ray for tuberculosis. But all too often, these tests are actually inconclusive, or doctors suspect co-infections. They don't necessarily actually affect the kinds of treatment, therapeutic decisions that are being made. And if patients remain undiagnosed and they don't get better on antimalarials or antibiotics, then at that point they're often treated for tuberculosis. And doctors often talked about tuberculosis as also something that's very prevalent in generally sick patients, precisely because it can appear in many different kinds of manifestations. And this has really important implications, both for therapeutic management. It means that ultimately treatment is often preceding diagnosis. It's a kind of trial and error medicine that's often practiced. But it's also really important for health information systems because diagnosis is often recorded on the basis of treatment rather than laboratory tests. And treatment itself is often determined by availability. So you ultimately have a system where the health information system is very much skewed by the availability of treatment. Now, many patients do receive firm diagnoses in hospital, but what the doctors call the generally sick patients, they are an extreme case. But I think the doctors' struggle to deal with these patients also reveals a health system that is very much struggling in the absence of any reliable laboratory infrastructure at either a rural or a hospital level. Now, this diagnostic infrastructure is currently undergoing dramatic changes. In 2006, the editors of a special issue of Nature on Diagnostics were able to claim that diagnostics received very little attention by comparison, for example, with innovative therapeutics from global health actors. But today, the need for effective diagnostic tools for low-resource settings is very much on the global health agenda. Following the development of the first lateral flow immunoassay test for malaria in the early 1990s, a range of point-of-care tests for diseases of poverty, including for sleeping sickness, HIV and dengue, have now become available. And Edinburgh University is very much at the forefront of some of these innovations in diagnostic technologies. At the recent EID Symposium on antimicrobial resistance and drug discovery and diagnostics, organised by Till Bachman here, many of these new kinds of innovations in diagnostic technologies were being showcased. But I think the challenge is really how to think about making such diagnostic tools affordable, accessible, and appropriate for health systems in resource-poor settings. And anthropological research can provide important insight into some of the challenges associated with the integration of new diagnostic technologies into established health infrastructures. So just to give one brief example, in 2010, a new malaria treatment protocol for artemisinin combined therapy was established in Papua New Guinea. In line with new WHO guidelines, that protocol required diagnosis with a point-of-care test prior to treatment. And this was intended to reduce treatment costs because ACT combined therapies are much more expensive than the original chloroquine drug, but also to reduce artemisinin resistance. Nonetheless, the rollout of the rapid diagnostic tests was accompanied by multiple challenges. So first of all, training. Now, the point of point-of-care tests is that they're meant to be extremely easy to use and not to require extensive training or laboratory training, but they do require some training, often to ensure they're used effectively in conjunction with quite complex treatment protocols, and to ensure that they're trusted by the health workers and that they're going to be acted upon. In Papua New Guinea, the training of health workers across the country was outsourced to a university-based consultancy firm. But this firm often found that it was impossible to contact the health workers across the country. In many cases, they failed to even communicate with them about the location of training. It needs to be taken into consideration that this is the country with no rural postal system and very limited mobile phone infrastructure. So the team leader for the training said, out of 20 provinces and provincial coordinators, we have 3 on email. Usually their office number has been disconnected, bills haven't been paid, we don't know if there's network coverage. And so ultimately they found the only way to get hold of health workers was actually to send a fax to Provincial Treasury, because that's often the only kind of a communication device that's actually working in a province. So it's quite a sort of extreme context, if you like. It's one that often policymakers and donors aren't really taking into consideration when they're establishing timeframes and targets. Then there were also problems with procurement. So the initial tender for the rapid diagnostic tests for malaria was written in such a way that only one medical supplier, there are only 3 medical suppliers in Papua New Guinea, and only one could be given the contract. And the government's chief pharmacist also happened to be on the board of directors of that company. When the Global Fund, who were funding the rollout of the rapid diagnostic tests, discovered this, they were not happy, and so they cancelled that tender and demanded that the Department of Health rewrote it. And a new company won that tender with a different rapid diagnostic test. Only the previous cassette rapid diagnostic test type had already been used for training. The original type had a line for control, a line for Vivax malaria, and a line for falciparum malaria. So very simple, easy to read. Unfortunately, the new cassette actually had the lines in the opposite order. So ultimately, this tender also had to be cancelled, and they had to go back to the first rapid diagnostic test. So there are many lessons to take from this, but one of them is that tests are not as simple as they seem. Minute differences, for example, where the lines are on the screen, matter. How many drops of buffer are needed matters. One of the tests required 5 and one required 3, and whether health workers use the right number actually has really important implications for how reliable that test is going to be. None of these things can be standardised, but the fact that there are differences actually makes demands on health workers for flexibility and for kind of awareness of those differences that are not always acknowledged when we talk about these tests and their mobility. Thirdly, there are problems of delivery. How do you actually get something from A to B in a country where there are very few roads? In Papua New Guinea, this is usually a matter of carrying. So this is an image of people carrying medications from the highway to that first health centre that I had an image of, which is about a 5 or 6 hour walk over mountains. They just carry them on their shoulders, or women carried them in large net bags hanging off their heads. So now there are questions about whether donor funding should be used to pay people to carry these rapid diagnostic tests because they're so essential and because it's really important to make sure they actually get from one place to another. But then there are questions about whether if people are being paid to carry rapid diagnostic tests, will they continue to carry other essential medicines like antibiotics, which aren't covered under disease-specific donor-funded programs? This is an ongoing question. Finally, another issue that hasn't been given enough attention in relationship to rapid diagnostic tests is temperature. Like many medical devices and pharmaceuticals, the RDT cannot be exposed to temperatures over 30 degrees Celsius or to direct sunlight. Nonetheless, these are various quotes coming from both the training coordinator and the first one from a health worker. All you need is the medicines delayed at the airstrip for 1 hour in the sun and they're finished. The sun hits, this is talking about one specific health centre dispensary in Medina province. The sun hits one side of the dispensary in the morning and the other side in the afternoon. Most dispensaries are well over 30 degrees. Rapid diagnostic tests are carried on the back of open trucks. They're left on the side of roads to be collected, and they're stored in hot dispensaries. So we might not need a laboratory infrastructure, but we still need other kinds of infrastructure, whether it's communication or transportation, or in this case, I think one thing that we need to think about is cool chains rather than cold chains. Perhaps most importantly, concerns about thermal stability also erode health worker trust in the tests. And this is really the same problem as I started with in the provincial hospital. If health workers don't trust tests, then you might as well not have it, because it won't change their therapeutic management of patients. And the same goes really for relationships with other kinds of diagnostics. So emerging research on point of care use of malaria RDTs shows that health workers still give antimalarials when there are no other diagnostic or treatment options. And we've also seen the rise of prescription of antibiotics rising. And this is one of the reasons why developers need to start thinking about multiplexing rapid diagnostic tests to be able to test for a whole variety of different common infections in places like Papua New Guinea. Now, many of these issues are challenges for policymakers and for public health experts. But the context of use for diagnostics is also worth thinking about in the academic laboratory. And I think multiplexing, for example, is one of those. A recent article in Angamwant Chemi pointed out that most diagnostics developed in universities never actually leave the laboratory. And the authors argued that researchers need to start thinking about the field and doing field tests much earlier in the research process. And this is where I think interdisciplinary collaboration with anthropologists or anthropathologists who are familiar with such settings, I suggest, is worthwhile. Thank you.
Thank you.